So very good morning. Sorry, next slide. So we'll just go through the MDRO cases first. So these are the rates of MDRO in the surgical ward from 2019 to June 2022. You can see that the rates are gradually coming down. However, Jan to June, we're still half year, and if we continue at the rate we're going, we'll probably be more than 2021. Our highest number of cases have been the ESBL clap Nemo, but you can see the CREs are quite high as well as the VREs. So this is something for us to keep an eye on. Next slide, Suhaira. These are the rates of multi-drug resistant organisms per 1,000 patient days. So if you can see 7U, though the numbers are high, but CICU in comparison to though the numbers are not as high, but in comparison to per 1,000 patient days, the rates are quite high. The lowest being 90D at 1.9 per 1,000 patient days. And followed by the pediatric ward, which is also 3.3. But the second highest is 6U. Second highest is neuro ICU actually. Also very high rates of MDRO. Next. These are the MDROs, both hospital, divided according to organisms, and you can see here MRSA is the highest in neuro ICU and 7U. MRAB clap in 7U, neuro ICU and CICU, CRE in 7U and 6U. And CRE, usually we don't have any antibiotics. The new antibiotics, which is a combination, is very expensive, 1,000 for a day cost, more than 1,000 for a day cost. And VRE is also going up, which is very concerning because VRE, if they are resistant, then we have to give linezolid. And as you know, linezolid, you can get optic neuritis as well as neuropathy if you give more than 7 or 10 days. Next. So we'll go on to surgical site infection. Go on. So I'll be going according to specialty. So this is for cabbage. You can see the rate for cabbage is, we started off quite high, but we've come down quite significantly. However, in 2021, we did go up, and now we are also a bit high. The chosen KPI for SSI for cabbage is 10 per 100 procedures. This is what was given and will be included as your CQA for your ward. Now it's 10 per 100, but I think eventually we will work towards getting it lower if it's a clean surgery. Next. Next, Zuhaira. This is for mastectomy. Mastectomy also we were down and then we came up, and then this year we are lower as well. So hopefully we keep going lower. And the CQA that was chosen is 5 per 100 procedures of SSI. Next. This is for craniotomy. Craniotomy, we started collecting data in 2019, was high. 2021, I think, because of COVID everywhere and around the world, everything went up. So we'll have to, go back to ground zero and start all over again. So I think we are improving, and I hope we continue to improve as well with the interventions that we're thinking of. Next. Craniotomies with EVD also gradually coming down, though there's no CQA for this. So maybe Viravan and team, y'all can think of coming up with a KPI on a reasonable KPI for your ward so we can work towards that. Next. So I just wanted to run through the compliance of the individual care bundles, individual components of the bundle for individual department. As you can see, when we initially started the pre-intervention, all the, our intervention compliance was low. There was no documentation. Basically, there's no documentation. But over time, our compliance went up. But unfortunately, if you see, all went up to 90 above and whatnot. But you see this year, it's coming down again. So I hope, the teams would please reinforce to our team. I mean, we have not had time to meet up with our cusp team for some time. I went off for my sabbatical, I've just come back. But I think we want something to be sustainable even if we are not around. So it's within your own team. Next. This is cabbage. Next, Zuhaira. This is for mastectomy. Similarly, the compliance was up and then now down again. Next. This is for EVD. EVD also not too good. I think something to work on, and we can all have a meeting again. You just need to call us and we can see how we can work on it. Next. Craniotomy also, hair management has been good. I must say that means everyone has been actually either snipping or clipping and no more shaving, and that's the best thing ever. Okay, go on. So I just want to say this was presented at our department at the SSI. We got the Safe Surgery Award in 2018, and we presented this at our EPSIC just recently. And I give credit to all the head of units for this is what our rates have been reduced by. This is not what is the rates right now, but from the start of our SSI Safe Surgery, projects. So, for LSCS, it's SSI reduced by 64%, orthopedic 53%, mastectomy 30%, neuro 26%, cabbage 15%. So I think this is very good because it's a new project, and we have a lot of more interventions that we can put in. So that's great. Next. So go on. No, so we don't need this. So next is hand hygiene compliance. So hand hygiene compliance has been not great. This is the rates. And I must say, this is only when we audit. So if we were not auditing, we should assume it might be a bit lower. Go down. And this is hand hygiene according to house officers. And you can see this is very, very, very bad. And, it just takes one person to be non-compliant for an MDRO to be okay. So even if all the nurses are 100%, consultants are 100%, but if 2 house officers are non-compliant, you'll already have a propagation of MDRO. Next. So this is medical officers, and I must say it's quite concerning that the rates in 7U and 7TD is very low among medical officers. If medical officers are low, then we can't blame the house officers anymore. Next. And this is consultants and lecturers. I'm sorry to say in CICU was very low, and we don't actually audit many consultants, and it's always top up. We believe it's monkey see, monkey do. If you see in the pediatric ward, the compliance in the levels are very good, and it's mainly because, the pediatricians are very good in their hand hygiene. Next. So this is on personal protective equipment. So we look at compliance on whether the healthcare worker wears their proper, PPE when they go into isolation rooms, usually MDRO or airborne isolation, to see whether they're wearing their PPE. And you can see here in neuro ICU, the PPE compliance has been low. 7U also low. So I think, the rates are the high MDRO rates with the rates of compliance reflects, it's kind of, showing or showing some association. Next. This is according to PPE compliance among category. Thanks, Aisha. I need to cut it off. I just want to show that the compliance among PPE. So consultants have been pretty good, except in July, but over time there's improved. We don't see many consultants going into isolation rooms, but medical officers, I'm very concerned about medical officers not using their PPE going into MDRO rooms. And we brought this up also. We've seen primary teams, medical teams, as well as surgical teams going into ICUs and then not using PPE over there as well. And that's how I think a lot of MDROs are being transmitted within the hospital as well. So I would please ask you all to reinforce this with your junior doctors. Many of them, as Prof April has said, we are a teaching hospital. Many of them come from KKM. Probably they do not understand our culture. So please remind them and also set a good example for them. Next. So this is OT audit. So as you all know, we do OT audits, and I present this at the OT subcom. So I'm not going to go into details. We've got a checklist to look at different, Zu, please go back to it. So one of the things that, we look at anesthetists, we look at nurses, we also look at surgeons. So for surgeons, we look at hand hygiene, we look at, how instruments are change hands and whatnot. So one of the things that recurringly has been occurring since we started this audit is hand scrub, so hand rub, surgical hand preparation, basically, because we don't do scrubbing anymore. We do hand washing or with alcohol-based hand rub. When we did this guideline with the surgeons, I think we used the eye surgeons, I think Aisha was on board, orthopedic also was on board. We said, and according to WHO guideline, the surgical hand prep should be done for at least 2 minutes. But unfortunately, we see a lot of doctors and also nurses sometimes, but doctors is more concerning. We see scrub nurses as well, as you can see here, but they do not do the hand hygiene, the hand preparation for 2 minutes. So go on to the next slide. So as you can see here, this is the compliance for surgical hand preparation. According to our manufacturer's hand wash, it says 3 minutes, but according to international guidelines and even our guidelines, we say 2 to 5 minutes. But most healthcare workers do it less than 2 minutes. And this is the compliance to it. Compliance is about 23% that actually do it for more than 2 minutes. Next. So this is according to the individual teams that we had audited. We must say we only audit 1 OT per month, so there's not many. We just go on rotation and we see who's in that. And you can see here, these are the teams that we have audited. You can see for yourself, and it's something. I'll come to the chat later. I must say some of the interventions have been done. Is that, and if you speak to our OT nurses, matrons, they have put a clock up in each room. We have put a clock up in. Sorry, yeah.
Somebody is talking.
So
Can you mute yourself, please? Lei Ting, whoever is Lei Ting, please mute yourself. Thank you.
Yeah, so it's important that one of the things that the nurses have done in OT is, and we discussed this before, was to put a clock in OT. And the nurses did say that some of the clocks were not functioning, but they told me that they've already changed all that, and they have a checklist now to make sure that the clocks in all the in the hand washing place has got a working clock. So maybe something again for the teams to reinforce. Again, we are a teaching hospital. We don't want these surgeons to go out and tell people that does it for less than 2 minutes. Next, unless there's a new guideline that says that you don't need to do it for 2 minutes. Next. So I just want to go through. So I myself was not sure. I thought there was a change in practices. So we went through to look at some of the guidelines. WHO still says 2 minutes. 2 minutes surgical hand scrub was associated with higher but not clinically significant bacterial count compared to 3 minutes. So that's why WHO came up with this 2 minutes. Again, another thing that says 2 minutes is required compared to 30 seconds. Next, Zuhaira. And then this is from WHO summary for systematic review by WHO, which also shows both studies show that equivalent to 1.5 minutes to 3 minutes in decreasing CFU, but they are talking about alcohol-based hand rub. That is something also for surgeons to think about, whether to change from hand washing to hand rubbing using alcohol-based rub, because everyone is going towards that now. It's very effective. Next. And these are some of the other systematic, the reviews that have shown why that time of number was used. Go on. Go on. And then this is environmental audit. I'm just going to go quickly. So environmental audit, this is the cleaning by both the facility staff as well as our PPK. It's not been too bad. Go on. However, in June, we see some reduction in CICU and most of the critical care units, because of our facility people we've been having problems with the contract workers, which the hospital is working on, I hope. Next one. So in summary, surgical hand scrubbing, I won't say scrubbing, it's surgical hand prep. So please change that later. Surgical hand prep, we should reinforce and try to improve. And we are, in any way that it can be improved, we can work with the OT staff with that. PPE compliance, also, I think we need to remind the medical officers, the trainees to do it. And hand hygiene, I think we still need to work on every level, because if we can't just blame our house officers, because I've spoken to some house officers, they just tell me that everybody doesn't do hand hygiene, why should I do it? So I think we all need to do it. So I think I'm happy to take some questions, and also if you have any suggestions, I'm happy to take it back to the team and improve. Thank you.